This next one here is Imposter number 3. And this is, without going through this sequentially or in finite detail, you can see right off the bat that this is a wide, complex rhythm. So we have a sinus rhythm. You look at V1 for P waves. We have P waves followed by a YQRS. So this is a sinus rhythm with aberrancy. Then we look to see if it's right bundle branch block or left bundle branch block. And V1 is downgoing, so we know it's probably left bundle branch block. And we see rabbit ears pattern in V5 and V6. So we have a left bundle branch block. Now what's interesting about this, though, too, is, of course, when you first learn to diagnose acute myocardial infarcts on a 12 lead, you get focused a little bit of tunnel vision on ST elevation. So, you know, if you look at lead 2, for example, it looks like the J point's up. Lead 3, it looks like the J point's up. AVF, nah, not so much. But V1 looks like the J point might be up slightly. V2 looks like the J point's up. V3, J point elevation. V4, not so much. But the point of this is that when you have bundle branch blocks or when you have ventricular hypertrophy, you get ST segment changes. ST elevation, sometimes ST depression, but these are not indicative of myocardial infarction. It's just a normal occurrence that happens with bundle branch blocks and with left ventricular hypertrophy or left ventricular strain pattern. So you recall that one of the criteria for PCI or for thrombolysis is presumably new onset left bundle branch block. Well, you know, if your patient has signs and symptoms consistent with myocardial infarct and they have this left bundle branch block and you don't know what their previous ECG looks like, then sure, it might fit the criteria for new onset left bundle branch block. But if you saw this and the patient did not have signs and symptoms consistent with myocardial infarct, then just ignore this stuff. We don't worry about it. It's just a left bundle branch block. It's a normal finding, and that's what we expect to see in a left bundle branch block. Now, just for interest's sake, I'm going to try to blacken the screen here. The other thing that sometimes mimics acute MI is ventricular aneurysm. And I've actually never seen this on a cardiogram, but a ventricular aneurysm occurs if there's a large area of infarction, an old MI, that leaves scar tissue. That scar tissue doesn't contract. And in fact, if the scar tissue is large enough, what happens is instead of the area of scar tissue contracting inwards when the ventricles contract, it bulges outwards. Now, that's a bit of an exaggeration, but it bulges outwards when this part is moving inwards and contracting, and that's called an aneurysm. And a ventricular aneurysm will give you persistent ST segment elevation. So this patient will have ST segment elevation in anatomically contiguous leads for the rest of his or her life. As I say, I haven't seen it personally, but that would be another example of a great imposter that would mimic MI. So you have to take that into consideration when you're looking at these patients. And again, if they've got signs and symptoms consistent with myocardial infarct and they have ST elevation, then there's not much choice except to treat it like MI. But if they have ST segment elevation in the absence of signs and symptoms consistent with acute myocardial infarct, but they have a history of an old MI and they tell you they've had problems with their heart and the heart not contracting properly, then you may be dealing with ventricular aneurysm.